So how long has the ketogenic diet been around? And in the first slide it says, even in the old days, okay, fasting was used as treatment for epilepsy. So it's even in the Bible, guys, okay? They said Jesus recommended fasting for prayers for the convulsing demon. So it's actually in the Bible. And in 1921, Dr. Wilder, so I don't know if any of you guys don't know Dr. Wilder. So Dr. Wilder is probably one of the eminent epileptologists in the country. He still lives in Florida, still speaks a lot. He's very passionate about him, but his paper is one of the ones that first came up with this particular approach. And then in 1938, Dalantin was discovered. So just like anything, it comes in waves, okay? So I think, I'm not even sure, I think phenobarbital is older and the benzodiazepines are older, and then Dalantin came, and the use of the diet decreased. And then 70s and 80s, they had Tegretol and Depakote. So a lot of the physicians, you know what we did, like what I said, you use this, Dalantin in combination with Tegretol in combination with valproate, okay, or like monotherapy. What you usually do is monotherapy, okay, because monotherapy means it's less side effects, okay. And then in 1994, I don't know if any of you guys remember this. Nobody remembers this? Yeah, so this guy who is a producer for Dateline NBC had a child who had intractable epilepsy, was on a bajillion drugs, and then found out, oh, the ketogenic diet worked for his child. So of course it got like a big press, and I remember this because I was just a fellow coming out, and everybody wanted to be on the ketogenic diet, and we all kind of rolled our eyeballs up and oh great, you know. So we had, anytime it comes out in the press, guys, believe me, the physicians' offices braced for 5,000 phone calls, okay? And then we're like, okay, this came out last night, this is gonna come out, so we warn our nurses. This is gonna be what you're gonna be expecting. Or sometimes it's the nurses who warn us. We saw this on TV last night, you know, because probably we're all too busy to watch TV, okay? And so 1994, it started to become more popular again, okay? So what are the uses of the ketogenic diet? And again, I think we were talking about epilepsy syndromes. So one of the first epilepsy syndromes we use it is Lennox-Gastaut syndrome. Lennox-Gastaut equals intractable epilepsy. Okay, so I don't know if any of you guys your children have, or your physicians have said your child is Lennox-Gastaut and wolf-hirschhorn. So that's one. This is one of the epileptic syndromes. Okay, the ketogenic diet is also life-saving in certain circumstances. This is one of the metabolic disorders. It's called GLUT1 deficiency. And what happens is these kids have very low CSF glucose. And if you don't diagnose that, you put them on seizure medicines, it's going to be intractable until you find a GLUT1 deficiency. It's well described by the Dr. DeVivo in New York. I've been looking for my first GLUT1 deficiency and I still haven't found one. So, but it's out there, and again, it's something we have to look for. Pyruvate dehydrogenase deficiency is a form of a mitochondrial disorder. And again, this is one of those that have been recently, in the past 2 to 5 years, been anecdotally reported that the ketogenic diet is quite helpful. Okay. Other deficiencies like infantile spasms is also helpful when the standard medications don't help. We call severe myoclonic epilepsy of childhood. So those are what I was talking about, epileptic syndromes. Okay. These are some of the conditions that you have to be careful when you're using the ketogenic diet. So I'm saying contraindications with a grain of salt. So your physician needs to be aware when you're starting the ketogenic diet, they need to rule this out first before they say, oh, so there's a fair amount of work involved before we put you on the ketogenic diet. So these are the conditions. Pyruvate carboxylase deficiencies, again a mitochondrial disorder. Defects of fatty acid oxidation. These are kids who might die when you fast them, so you have to be careful, okay? Like we call medium chain acyl dehydrogenase deficiency. So you have to rule that out, because if you put them on the keto, if you do the fasting part, they will go into what we call metabolic decompensation. And so in kids with mitochondrial disorders, okay? And again, I think mitochondria is becoming a little bit more popular in the wolf-hirschhorn group. This needs to be investigated before they start the ketogenic diet. And I would say 99% of the neurologists know how to rule this out. It's fairly simple, okay? carnitine deficiency needs, and that's just blood work, okay? And then children with long-term use of steroids, they may have problems. Okay, so what are the goals of the ketogenic diet? It's improved seizure control, okay? And the nice thing that a lot of the families like is the second one, minimize medications, right? Because less medicines, we think it's better control, okay? So let's go through, okay. So what is the basics of the ketogenic diet? Have you heard of the Atkins diet? So it's sort of like that on the extreme end, okay? So the diet stimulates the effects of fasting on the body, and it uses, what's the first line? So when we have energy, when we're walking, when we're doing the treadmill, what do we use first? Carbohydrates, right? Okay, remember, don't remember the glycolytic pathway. I have a young lady here, maybe she remembers the glycolytic pathway. So that's where you go straight into, is the glycolytic pathway. What happens with the ketogenic diet is we don't use the glycolytic pathway. We use fats to break down and give us energy. Okay, so the presence, we think of ketone bodies, which is what happens when you excrete ketone bodies. We think that's the main basis of how you control seizures. Okay? Diet, high fat, low. So just like the Atkins diet, it's high fat. Like, you know what they say, you can eat anything. Although in ketogenic diet, it's not. We have to count the calories. So high fat, low carbohydrate, low protein diet. And the ratios we use when we're starting is 1:1, then we go to 2:1, 3:1, and then 4:1 is the highest. And that's a fat to carbohydrate ratio. Okay? Usually in the ketogenic diet, I heard one of my good friends give this lecture. He said, it's not an easy treatment for a medication. Oh, here's your medicine. You may have to fight a little bit, but that's it. It's over. In ketogenic diet, we have to do a lot of preparations. We have to weigh things. We have to look at the calories. For families who've been on it too long, it's no big deal. But initially, it may be a little bit more difficult. Okay, so we expect a lot of commitment to family members. So families who don't want to do all the little itty bitty things, I say through the ketogenic diet, it may not be helpful. Okay, the nice thing about the ketogenic diet is that a lot of the studies all throughout America, anywhere from Harvard to Hopkins to even Children's Hospital, you can see the effect in the first month. So if you don't see an effect, don't worry, it may work, but that's the nice thing that families like, okay, is that you have the effect within the first month of initiating the ketogenic diet. Okay, mechanism of action, a lot of words, guys, okay, I don't expect you to, these are big sentence words. The one thing about medicine is that if something works, we don't stop there. We go, well, why does it work, right? As physicians, why does it work? We have to analyze it so that we can maybe transfer that to medicines in the future. Okay, so we think there's several hypotheses with regards to how it works. And we think that you have energy, ATP hydrolysis, substrates to the brain so that provides energy to other systems that may help in the energy of the child's brain, okay? And then the third one, it says the ability of beta-hydroxybutyric acid, which is one of the ketone bodies, to oxidize coenzyme Q, which is very important in the glycolytic pathway and in the energy-producing part of your body. Okay. And I think in this slide, I think I want you to remember what Dr. Battaglia said about the GABA receptors. Okay, so you see here in this slide, so it increases GABA synthesis in the brain. Okay, do you guys know what GABA is? GABA, or gamma-aminobutyric acid, is an inhibitory neurotransmitter. Okay, because what happens in the brain when you have epilepsy, it's excitatory. So what we want to do is bring that excitation down and do inhibition. Okay, not too much inhibition, but at least enough to lessen the seizure. So this is fairly exciting because just came out in 2007. Okay, so we like that part, that it may have actions on the GABA receptors. Okay. Okay. So there's three types, actually two types of initiation of the ketogenic diet. We have the fast initiation. Okay. And the gradual, okay? So in the old days, what we did was more of a fast initiation. So what happens is we dehydrate the kids. Okay, so they have nothing to eat in about 24 to 48 hours. Sometimes what we tell families is before they get admitted, and all of these patients are admitted to the hospital, guys, okay, because it's not safe. Do it at home. The one thing about the modified Atkins diet is you can try it at home. With the ketogenic diet, it has to be supervised at all times, okay? So it has to be, it's sort of a team approach. So in the old days, we used to hospitalize the kids with a 24 to 48 hour fast. Nowadays, the newer mode is a gradual initiation so that they're hospitalized and we try the ketogenic diet on a 1:1 basis. In the old days, we used to fast them like 24 to 48 hours and they have nothing at all to eat. Okay? And then the one thing I highlighted this is in the old days, if I have any families here who've been on the ketogenic diet before, in the old days we dehydrated them, now we liberalize the fluid so that because we're afraid of the dehydration phase. Okay, because remember what I was talking about in mitochondrial disorders, you cannot dehydrate them. So sometimes you cannot, in mitochondrial disorders, we may not know, it may not be obvious at first, so we kind of try to avoid that part. Okay, so this is a study out of CHOP, I think in the past, yes, sorry.
Back on that previous one, my daughter is about to be initiated at Children's Hospital in Denver next week, and they are doing the 24-hour fast, and then they start around 1/3 calories the first day, 2/3 calories. Maybe I misunderstood you, but are you saying that that's kind of the old way to do it? And now it's not fasting?
Well, yeah, so it depends on how the only thing that we try to avoid with the 24, and I'll go through it. Okay, so for example, when you were asking, so they did a study, the CHOP people did a study on a gradual versus fast initiation, and they had 48 subjects, and so these people said, what's better, a gradual or a fast initiation? And the thing, and I'm not saying fast is bad, it just depends on what the team is more comfortable with. But they were trying to say, well, what if we do a gradual initiation? What are the good things about a gradual initiation? So in this group of people in CHOP, 67% versus 58% of them had better seizure control. So the 67% of the gradual kids had 67% control compared to 58% for the fast. Okay, but this is a small group, 48 kids, okay? And then on the gradual side, 94% were better controlled on, so 94% control on the gradual versus 78% on the fast, okay? And then what happens with the fast is you have less side effects. Why? Just imagine a child who's not eating for 24 hours, guys. What do you think? They're going to be very irritable. So when we do studies, side effects, boom. Irritability, boom. Then we check. Okay. So I think when you say why is it better, it's because we try to eliminate the side effects. Okay. And again, that's my main worry when kids have a acute metabolic decompensation. If they have but if they've ruled out a mitochondrial disorder, then I'm not so worried, okay? But yeah, so a lot of the families has less side effects, vomiting. Of course, if you don't eat 24 hours, you get dehydrated, and then you're irritable, and then, your child is with you. The doctors walk in, and then we walk out, so we don't see all the irritability. So the families have to go through that 24 hours of irritability. Okay, and then obviously hypoglycemia. So if you're not eating for 24 hours, really it's hard for us to give D5 because that's glucose. That's what we're trying to eliminate is the carbs. So it's a very careful balance. Okay, seizure outcomes. So some centers still do the fast. It just, as I said, it just depends on how comfortable they feel. Okay. So Freeman, who is actually sort of the god of the ketogenic diet, had this study in 1998. He followed more children, 150 kids between 1 to 16 years of age, and they followed that in Hopkins. And you can see, guys, okay, that the seizure control, so at 83%, so the blue on the diet greater than 50%, and then greater than 90%. So they had this is what you want to see, right? I mean, like that's maybe aiming for the moon, as I say, but 30, it's a fairly good response, at least 30%. So a family who's having, as I said, bajillion seizures, okay, like 500 seizures in one day. If you go from 500 to 50, that's like 90%, right? And as a family, that's like, wow, that's very impressive. As a physician who's having to pile one drug after another, I'm ecstatic when I hear that, So 50 still sounds like a lot, but to go from 500 to 50 is big time for me, okay? And then to go from 50 to 10 is even bigger. So that's what we see in some of the kids that are chosen for the ketogenic diet. And then this is an Asian study done by Kang in Korea. He had even more kids, 200 kids followed on a diet. So almost the same statistics as the group in America. Okay, so as you see, the seizure-free is about in the 30%. Remember that, guys? Okay. And then the greater than 50. So when we talk about 500 seizures, it went down to 250. And then, or 10 seizures, it went down to 5. So you see that. Okay. Okay. Kossoff is one of the people who advocates for the modified Atkins diet, and he is a Hopkins guy. And so they did 28 out of 386 patients, started on the diet between 1993 and 1999. And they remained on the diet for at least 6 years. So it's not too bad. Then that's the point of that first sentence there. They were on the diet for about 6 years. And then again, it's a long-term commitment. Some of my parents have to be on, I call the obsessive-compulsive side because it's fairly rigid. And so it's, those families, it's not such a big deal. 24 of those patients had greater than 90%. And then one thing is a lot of patients cited lesser side effect profile. So again, it's a lesser side effect profile that we advocate for alternative therapies. Okay, so how do we start the diet? Full metabolic evaluation, and I have like a long list behind this slide. If we suspect a mitochondrial disorder or a metabolic disorder, I said here muscle biopsy, but not necessarily. We do have some blood work for mitochondrial disorders, what we call point mutations, Paul G1 screening, so a fair amount that are now like genetic. See with blood counts, electrolytes, so sodium, potassium, chloride, and all that good stuff. BUN and creatinine are your renal functions. We also do magnesium, selenium levels, which we do selenium levels because we think that sometimes some of the kids in the ketogenic diet may have a relative deficiency. So a big list, right? And that's when the families come up to us and go, oh my God, you took 3 vials of blood, and then, my child needs a blood transfusion after this. I'm like, sorry, but we need to do it before the diet, and sometimes we even follow it after the diet, okay? And then you saw here full labs at certain points in time, and sometimes in children who have certain disorders that I may have to follow it more closely. So for example, if you have renal issues, this is just standard. Each child with tailored therapy depending on the child, okay? So whenever you're asking questions about what should I do with my child, there's no standard. Each child is different because each child has different side effects. Each child has different responses to different medicines. Okay, so each child is very different. Okay, and then as you see, we say limited labs. Okay, so in between we follow them. In kids with side effects, we follow it even more closely. Okay, okay. So here you go. So and because we're limiting the carbohydrates in children with the ketogenic diet. So all those syrups have to go, okay? So we have to change into tablets, we have to crush the tablets. Like for example, if your child's on phenobarbital can be crushed fairly easily. The one thing about Topimax is you cannot put it down the G-tube because it will plug it. So if you have a G-tube, we have to crush Topimax, okay? So sometimes some of the sprinkle forms may be difficult. So how many of these kids are on Depakote? I don't know, are any of your kids on Depakote? No, none? Okay, so it's an older medicine, so a lot of the epileptologists here in America, we don't use Depakote as much as probably the Europeans do. So anyways, we have a clinical pharmacist to help us if there's like if you're in the ketogenic diet and your pediatrician starts you on an antibiotic, a lot of times that triggers a lot of the moms to call us, is this okay? Because we want to make sure, because a lot of the antibiotics, the elixirs, are of course sweet, right? Because the kids like something sweet. So, so we say use the antibiotics first, the tablets. Okay, so you have to kind of watch out for that. Okay, this is one of the aids, is a keto calculator. Do you guys have this? No, okay. So this is available. A lot of the dietitians use this in terms of calculating the carbohydrate and the protein ratio, guys. Okay.